100 years of Indian ophthalmology focusing on glaucoma aspects. I invite all the chairpersons, moderators, conveners, all to the dais. I think because of the restriction of the time, we have to restrict our discussions. So we won't have any discussion because if you start discussing, then one or two speakers will be out of the section. So the first speaker, Dr. Vikram Jain, is ready? Yes.
Can I have the presentation,
he will be talking on beyond the basics of perimetry.
So we would request the next speaker to be ready on the podium so that there is no loss of time in between two talks. The next speaker is Dr. Bipul Kumar Sharkar. Is he here? Dr. Sharkar? The next speaker is Dr. Anish. Anish is here? Yeah. So I think you can load up your talks. Yeah.
8 minutes.
Yeah.
So the time allotted for each talk is 8 minutes. You have to stop at 8 minutes. Please cooperate.
Yes, thank you. So I won't be covering anything about single field analysis. It's something we can go directly into it. I won't be covering anything about single field analysis. Let's just assume that everyone knows how to read a single field analysis printout. Now we'll try to cover whether this the perimetry is really glaucomatous or not. What about the reliability, what differentials you should consider, what test to use when, and a little bit on modern progression analysis. So visual field in glaucoma classically begins in the mid-peripheral area with a cedial scotoma going on to become an arcuate or a double arcuate scotoma. So it is generally asymmetrical across the horizontal midline. That is what we should always remember, and the location, as I already discussed. It should correlate very well with our disc findings. We have the classic criteria to diagnose the field. The important thing to remember is that the same points are there on consecutive fields. It is just not one printout which matters. For example, in this particular printout, it's perfectly satisfying the criteria mentioned previously, but 1 week later we repeat the field and there you have the effect of the learning curve. Although the previous field perfectly satisfies it, and perhaps if it was a concentric cupping, it would correlate with that also, but then there's always a learning curve for visual fields, and therefore on two consecutive fields it should be perfectly repeatable. All these defects should be perfectly repeatable. We should also look at the bottom of the chart. If you see this printout, even in the first field it was perfectly reliable. Everything is within 20. Zero fixation losses, false negatives 13%, false positives only 3%. At the bottom you have the gaze tracker, an upshoot which would indicate when the patient is looking away from the center, and a downshoot when the patient has a blink or has slept off. So even the entire length of this gaze tracker would give us an idea as to how long the patient has taken to respond. As mentioned earlier, it should perfectly correlate with the fundus picture, with the disc findings. There are multiple lesions which can produce arcuate scotomas, either in the retina, or just a BRAO or a BRVO also can produce an arcuate scotoma, or disc lesions as well as optic nerve lesions. Again, one more example wherein it's perfectly an arcuate scotoma satisfying all the criteria mentioned above, but if you look at the fundus picture, it is because of disc drusen inferiorly you get this picture. when to apply which test. Now this, we would all know that 30-2 has no value here in a more advanced field, and therefore a 10-2 field would give us a more magnified view of the central field, which would be more useful to prognosticate this case in the long-term follow-up. But also in fields like this, wherein the field loss is very close to fixation, quite deep there, a 10-2 has more value because the central points, you need to follow up them closely with the overview analysis. And in such a patient, 30-2 alone won't be enough. For every follow-up visit, we have to do a 30 as well as a 10-2 to look at the central points too. For progression analysis, classically we used to use the overview analysis and then try to look for new field defects as well as deepening of scotoma. There were criteria which were defined. This would be time consuming, and most practitioners would just look at the mean deviation and look at that. Only if the mean deviation had dropped a lot, then they would really analyze where the progression is there. This is one example of a progressing field. In this example, we see that the field has progressed rapidly towards the bottom, which is not classical with glaucoma. Even so in the other eye. If you look at the values there, they're visible, yes. They're all 0. It's not a relative scotoma, it is an absolute scotoma there. This can occur in a glaucoma patient if there is some concurrent CNS lesion too. So always remember, it is not only glaucoma which is causing a progression, there might be something else. The same field effect magnified. So everyone progresses. It's a matter of how fast our particular patient is progressing, what the age of the patient is, and whether this progression will have any bearing on the patient's quality of life. Which type of progression should we intervene in? Now, this particular chart is there in all our modern perimeters. The GPA summary would give this. The rate of progression analysis. Here the visual field index, something similar to mean deviation, not exactly mean deviation, which is corrected to the age of the patient is used, known as the visual field index. This is plotted against the patient's age. And over the past records, here you have all the patient's previous records, and then the slope is then determined. You have the loss till date from the baseline, projected loss over the next few years, 5 years, that is given. So we use this chart, and just an example of how this visual field index can influence the patient's quality of life. In the initial part, wherein its VFI can drop to 80, is when, especially if the patient has an inferior field defect, the patient is more prone to some falls. Once it comes below 60, it's driving difficulty. Below 50, the patient has problems in reading, and when it is below 30 is when mobility is affected. In this example, you have a small field defect here. Although it is very small, this patient may not perceive here, and then he would extrapolate that there is nothing there while there is actually something there. Because he had that field defect, he may be missing it, and therefore mobility and driving becomes a problem. So when we have these sort of charts, trend analysis of progression, these are very useful. So in this particular patient, he is progressing slowly. His age is given against this plot, 81 years old. Over the next 5 years, he is not losing around 20% of his VFI, which may not be significant in such an elderly gentleman. But if either his age is younger or the field was progressing very rapidly, like here you're seeing that the field VFI is already 40%. The minute it comes below 30% is when the quality of life is severely affected. This is when we have to intervene in the form of a surgical intervention. With this, I conclude my talk. Thank you.
So, Anish Nikhara. Dr. Anish Nikhara. Next speaker.
Yeah, the third presenter.
Second presenter.
Saurabh is already there. So your presentation is on the other. Okay. Yeah. So it is. No, he's not the one. No?
The practicing physician in the Chicago region, basically deal with 50% neuro, 50% neuro. I don't know why I'm in glaucoma, but it's okay. I think it's a relevant topic for all of us. especially when we are celebrating this 200 years of ophthalmology, we should also know our limitations and whatever we have not yet achieved. So when I talk about neuroprotection, basically it's a defined neuronal loss or dysfunction we can avoid, we can slow the progress. It's not like nobody done anything. It's almost more than 1,000 strategies being tested or in process so far. But it's like in US we say that whatever bad or good things happen in Las Vegas, it stays in Las Vegas. Same thing, whatever good things happen in animal experiments, it stays with the animals. Nothing went into the human trials. So part of the deal was either the experimental methodology was bad, or we did too much interpretation out of those small molecules, or it's easy to kill the animals and do the analysis versus difficult in humans. We still do the assessment based on the entry part of the optic nerve, but we're still not sure how the somatodendritic features can be seen in vivo, although the neuroimaging features can still show the progressive brain changes in these patients with glaucoma too. And obviously the time course, like it's easy to do something in short time versus the long time. So I did this sort of maths calculation. If you really want to calculate the geographical atrophy, so again, my talk is more biased towards retina. So at one point of time, it's like one RP cell is dying on the floor. So it's really difficult to see the endpoint death signals of that RP cells. And when we don't know much, obviously we are shooting here in the dark, basically. So we know all these small common pathologies, including oxidative stress, mitochondrial dysfunction, protein aggregation. I'm not going to bore you with this lot of research here, but bottom line is we need to control both apoptosis as well as necrosis. And we know that part of the thing is like apoptosis mainly affected the photoreceptors, RPCs mostly die with the necrotic features. So it's necessary to block both the things to achieve a good success. Now, we know that there is a platelet-derived growth factor, the big two clinical trials will fail. Part of the deal was we just focus on the monotherapy. We just looking at the vascular pathogenesis of the AMD or diabetic retinopathy versus we were missing the neurodegenerative part of the trials. So it's fair enough to say that since the advent of the anti-VEGF agents, Avastin, Lucentis, Eylea, maybe around 90% of the patients can avoid moderate vision loss. But physicians like me who are kind of fourth physician for the retina cases or kind of referring physician for all the dumb cases from ophthalmology or from neurology, if I go with my own data and forget about my own data, this data, almost 90% of patients showing macular atrophy changes in the anti-VEGF group after 4 or 7 years. So, you know, patients feel like this doctor is just charging me money, giving injection every 2 months or 3 months. You're just doing that, nothing else you can offer me. Patient could be a small pharma in Chicago area or maybe a big celebrity, but everything we're just doing as anti-VEGF agents. So nothing else we can offer those patients. So basically it's thumbs down all the time with the patients. So it's just all thumbs down. You have nothing else to offer other than anti-VEGF. So we're waiting for some golden drug. We just keep waiting and waiting, or maybe just waiting for this golden drug, but I guess I don't have anything to offer you. But let's talk about some adjuvants. If not the gold, let's talk about compromise on the silver or bronze. So if we have something more to add into our current regime of, like in glaucoma pressure lowering agents or in retina in anti-VEGF agents, we can achieve better outcomes, I guess. Now, usually in my private practice, the combination of patients of neuro or the patients with the rheumatological problems, patients with the cancer problems, and I'm also treating their AMD or diabetic retinopathy, macular edema and all. Not so much of glaucoma, by the way. So there are certain things that you can do or you can look for potential things. So it's just a brief overview. It's difficult for me to collect everything in 8 minutes, but a lot of hypes about the complement antibodies, they just failed flat. A lot of companies lost pretty good number of dollars. The complement factor D antibody, it was pretty aggressive to start with. It did show 20% decrease in progression in the geographical atrophy, but overall we did not see too much of efficacy. This is another good way of looking for the neurodegeneration, visual cycle inhibitors. Pretty good, extensive, but still in the phase 2 study. Stem cells, there are a lot of hypes about stem cells for over the years. But at least we have one thing now. We have pluripotent or mesenchymal cells. We can have a source of growth factors from those cells. If they're not the regenerative therapy, but at least we can have a source of the growth factors. We know that this paper a long back, bromelain could be good for the patients in terms of neuroprotection, but Cochrane review was like kind of inconclusive. But still, it's a good one to look forward for a long-term study, to look at the clinical viable outcomes. I can also look for this geographical atrophy for this molecule. Statins, commonly used everywhere. It's a big group, high-dose statin. You can see the big difference of the resolution of the drusenate antibodies. Drusenate changes back into almost normal platform. However, I don't see anything like similar in every patient. There are a lot of subclassifications, a lot of sub-studies need to be done in this kind of patients. But still, it's worthwhile to look into this as a long-term study. Again, we don't have too much of sufficient evidence to prove that statins are useful, but it's worthwhile in some of the patients with a lot of exudates. And it can slow the progression in the CFH risk allele. Lot of things going on vasculitis, Viagra, we know everything. It's like a blood flow restrictions into the choroidal blood flow. Maybe it may be useful. Role of glutamate. It's always a topic of interest all the time over the years. And in fact, this new paper with the intravitreally administered memantine may be useful in optic nerve crush studies. However, in the past, we did not see too much evidence in the glaucoma trials. But still, somebody can do something more with the endogen metabolism. It could be a neuroprotective in glaucoma. Erythropoietin, I can still willing to give injection for the NIN patients if they're willing. In the past studies, up to 3 months, there's a sustained improvement, but not more than that. It needs for the more long-term study. I use levodopa sometimes for my Parkinson patients and NIN patients too. Maybe or may not be, but it needs some long-term studies too. I'm not too much impressed with the hyperbaric oxygen, but the Japanese group, they're making almost like ketone antibodies, ketone bodies with eye drops. They're basically attacking the serotonins, the aging gene. It may be helpful in terms of neuroprotection, and maybe very cheaper alternative like resveratrol and all. But again, things are awaiting for the long-term study. NG2 blockade could be very useful in patients with the non-VEGF responders. It could be a futuristic issue too. Nonetheless, when we talk about the combination of Lucentis with Ang1 inhibitor, we did not see too much of visual outcome as such. Fast ligand, it's an interesting molecule, because it's basically a destructive molecule, but in the soluble form, it could be a very neuroprotective too. Lithium, I used to avoid these psychogenic cases all the time in my practice, but nowadays I'm inviting all those patients. Maybe it's a neuroprotection. Let's see the EMD patient with psychogenic on lithium, how much they're doing well or not. I'm using this tacfidera molecule in multiple sclerosis for neuroprotection in diabetic macular edema patients too. Again, not so much data I can tell you, but it's fairly impressive in terms of disability progression equivalent to neuroprotection. Some of the new possibilities could be glial-derived neurofactors. Ciliary neuropathy, they have a very good platform, sustained release platform. They are still in the phase 2 clinical study. Increase in retinal thickness we observed pretty good, but still we need to see how much the visual outcome will be. And this kind of amyloid beta, all these Alzheimer's patients that I see all the time, alpha B crystalline, these are really useful molecules for the futures, but we don't know yet. Photobiomodulation could be very cheaper alternative for the patients with anti-VEGF and simple biomodulation. And these kind of patients, I see every time. There's a new concept coming in the US now. Every other patient is asking me to prescribe cannabis because of the approval of the cannabis for recreational use. But I have to sit back because there is a lot of cannabis receptors in the retinal circuitry. It may be neuromodulator. It may be affecting some of the scopic vision. And it's worthwhile to look for more research on this perspective. Antibiotics, some of them we know that minocycline doxycycline could be neuroprotective. I would love for Indian colleagues to look for rifampicin. It's a very good antituberculous drug, but something to look for in neuroprotection too. Steroids, we know that, everything. I think it's so short period for me to cover everything, but that's what I wanted to say. Thank you.
Just one question or one comment. That is, two new drugs are now available. There was Elvian and Vyzulta and Rho kinase inhibitor. That is Vyzulta is a nitric oxide donor. They say that it's a good, I mean, they have a chance of neuroprotection. And also the Rho kinase inhibitor, they say that is a neuroprotector also. That is also marketing in Japan and also in USA. So Vyzulta and Rhopressa. Both are available now in United States, I believe.
It's not like a standard way to use that yet. Like if I look for my patient to prescribe all these things, the insurance company of that patient may not allow me to do that. Or there will lot of ifs and buts of those patients basically.
Okay, we'll thank you, doctor.
Yep.
Next we will have Vipul Kumar.
No, please.
Saurav. I think we will have Saurav.
Thank you very much for the invite, AIOS, and to Dr. Natarajan and Arupda. It's great to be back home, and actually Indore is home for me, so Delhi College is my school, and medical college as well. But what we are here to celebrate is 200 years of ophthalmology in India with the institute in Chennai, which was built just a year after Moorfields Eye Hospital, which happens to be another of my alma mater. So what we're going to talk about is a few concepts in the glaucoma surgery nowadays in the next 7-8 minutes. So Penko, my mentor, would say that we need a surgery which has pressure of 10, surgical time of 10 minutes, and lasts for 10 years. And I've added a few of my own as well. But unfortunately, there is no surgery which can achieve all these requirements of ours. So there is no glaucoma ideal surgery as yet. All over the centuries, all we have done is lower the pressure, and that's all we can do at the moment. We probably have neuroprotection in future, but we don't know. So we can either increase the outflow within the eye or outside the eye, or reduce the inflow. So when I became a consultant in 2009, I had only these 6 or 7 options which I could do, and these are still some of my favorite options. But now in 2019, I have nearly these 16, 17 operations available to me, including outflow procedures, inflow procedures, and still those old procedures still remain my favorite, along with phaco ECP on top of that. We have all these new devices which have come in the market, and we have used all of these in our institute as well. CyPass has now been withdrawn because of endothelial concerns. So I'm just going to share a quick case study with you. 45-year-old chap with very high pressures of 60 and 50 with steroids and very advanced glaucoma in one eye and very early glaucoma in the other eye. So when you have a very real glaucoma like he has in the right eye, you need real surgery, and that is trabeculectomy at the moment. And he's doing really well after that. This is 4 years since the operations. And the other eye we did phaco and eye stent, and again he's doing well for that eye. But obviously it doesn't achieve very low pressures. So this is eye stent G1 going into the Schlemm's canal. And once the eye stent goes in, you see a bit of reflex of blood where you know it's in the right place. And sometimes in clinic you see this reflex as well, again telling you it's in the right place. But they do tend to scar and doesn't work very well. And this is the Zen Stent. Again, this is the ab interno external implant going underneath the subconjunctival space. And again, these have their own complications, and the success rates are less than 50%. So we have reviewed all the mixed devices with phaco, and we find that there is a floor effect of about 15 pressure with any of these devices. So you don't get very low pressures. And they are very expensive, nearly costing 50,000 to 100,000 rupees. So they're not really applicable for the rest of the world or for everybody. We reported the first case of endophthalmitis with a Zen implant as well. So in summary, if we talk about just the MIGS, then it's work in progress, and they're only for early and moderate glaucoma, and there may well be scope in future. But for me, trabeculectomy still remains the gold standard for glaucoma surgery. And a well-done trabeculectomy achieves the right level of pressure, and it can be made safer with the new techniques like the Moorfields Safe Surgery System. But actually, if you look at the development of trabeculectomy over the years, how it's happened is that sclerostomy came first, and then Colonel Elliott in Chennai, he actually modified it to become a corneosclerostomy. And he brought the sclerostomy edge forward. And then John Keynes, in his paper in 1968, mentions that Ilias procedure is now being modified by making a guarded sclerostomy. So that is exactly what trabeculectomy is at the moment. A guarded sclerostomy, a partial thickness flap guarding the sclerostomy or corneosclerostomy. So India played a role in that because Colonel Elliott developed this trephine here in Chennai, and that's what we are celebrating today. So PTVT study, the TVT study showed that the tubes work better when you look at the 5-year results. So we thought, why not look at the primary results for primary surgery? So I was lucky to be part of this PTVT trial where we recruited over 250 patients around the world, or 240 patients around the world. My mentors Keith and Sheng were part of the trial as well. And in fact, half of the patients came from 3 of us in this trial. And the first year results showed very good pressures of about 12 in the trabeculectomy group, which was lower than the tube group with better success rates. The failure was higher in the tube group. And the 3-year results will be presented at the AGS this year. So what we find is that in the PTVT trial, the tube had more failures, wherein the TVT trab was more failure. So we looked at why this could be the reason. One of the possibilities is that we are not using mitomycin for tubes. So that's the new study we are doing now. We've recruited 24 patients, which is comparing tube versus trab with MMC and without MMC. So for me, current indications of tubes are failed trabeculectomies, difficult eyes where the success of traps can be limited. This is another trial which I've been part of, is treatment of advanced glaucoma. We've recruited 440 patients, medication versus trabeculectomy, and we're due to report soon on this one. So what about advanced glaucoma with high risk of trap failure? So in these patients, I do a combined surgery, which is a trabeculectomy and tube. So we put Embarvel 350 with mitomycin, and this is not minimally invasive, it's maximally invasive for these high-risk patients. And we put a ligating suture and a supramid stent suture as well. We've shown good results in our hands, and we are going to present this in ARVO this year. So for me, if one take-home message is there from this talk, is that pick up the progressive glaucoma and refer these patients or do the surgery early rather than poisoning them with more and more drops. Because the first success of the operation is the best when the operation is the first time. You don't want to be putting too many drops and then the patient or the eye is very ill and then the success of trabeculectomy is really poor. We really need to use our bar very judiciously. So what can be combined? We can combine maybe a wine at dinner or maybe, but not everything at the same time. Otherwise, we will be sick just like this. So another of my mentors, Paul Foster, was instrumental in these trials, and I'm just going to touch on these very briefly. So is lens extraction helpful in angle closure, and is PI helpful in early angle closure or suspects? So the EAGLE study, which again I was part of, was published in 2016, and it showed that the lens extraction is very effective and gives better quality of life, better IOP control, and is more cost effective as well. So it was a very pragmatic trial, but the key thing is that these are angle closure patients with pressures over 30 or primary angle closure glaucoma. So these are not patients with any angle closure, it's only with established disease, with a 3-year follow-up. And 60% of the patients after just lens extraction don't require any drops afterwards to control the pressure. And you can see why. As the lens grows in the eye, it has a big effect on the anterior chamber, and once you remove it and replace it with the IOL, there's plenty of space and increased outflow as well. This is very briefly ZAP trial, which is going to be published in Lancet very soon. 889 patients who were randomized to PI and a fellow eye control. And it basically shows that you need a lot of patients to prevent angle closure. And they are going to say that it should be offered only those with highest risk of primary angle closure glaucoma. So our traditional thinking has been that PI is very good, but actually what the trials showed, lens extraction is very good and PI has a very limited role in very early stage disease. So this is another new technique which we have started called phaco IOL and ECP, along with endoscopic synoculysis. So these are patients with very advanced angle closure with very high pressures and who have got more than 360 degree of synovial closure. So from this, very brief, in 8 minutes I can't cover everything, but take-home messages are mixed. They are only for early glaucoma, they are work in progress, and they may or may not be cost-effective. Trabeculectomy remains the gold standard. First surgery has the best chance of success. They refer them early. Tube surgery is reserved for complex glaucoma, and lens extraction is very effective for angle closure. Thank you very much.
Really, it was really enjoyable. We went through the entire journey of the glaucoma surgery and what all things, new things, and we're just waiting to hear the results of this, especially the one that you talked about, the tube and the trap together. Thank you very much. So we call for the next speaker, and that is Dr. Abha Haidara. I hope I've got the pronunciation right. He's already there? I'm sorry. Okay, it's Vish Padmanabhan. Dr. Vish Padmanabhan, please. And I'll call the next speaker also to be ready. Is it Dr. Neeru Gupta? Yeah, okay.
Which one?
Thank you very much. It's fortuitous that I followed on from the last talk because lens removal has been my primary method of management of PAC and PACG since 1997. As the last speaker said, this has been validated by the recently published EAGLE study. And what it is, this is a preventative and at most part curative form of intervention. And the cost effectiveness we know, but it's also extremely clinically effective. EAGLE study again, as the last speaker mentioned, it showed greater efficacy and was more cost effective than laser PI. Now, looking at the epidemiology, I did think 20 years ago that it was mainly an East Asian disease, but since then it's been shown that it's actually very common in South Asia. And with Myanmar having the highest reported rates to date. Now, what PACG is, it really is a biomechanical condition. Pupil block, bladder virus, lens-induced, whatever mechanism you want to say, the cause of all of it really is a crowded anterior chamber. And removal of the lens resolves the overcrowding, so you create space. This is from this article, which is actually a very good article if you want to read through that one. Ultimately, everything is caused by crowding. Now we can see lens growth. Lens growth really takes off between 20 and 50 and keeps on increasing. So ultimately, it's the lens which, whatever mechanism you have, that is the one, the growth that actually triggers the thing off. It's not the other way around. It's actually the lens growth which is the most important thing. Now, the current dilemma is this. What we do have a very safe and effective solution for angle closure disease, but we're not really sure which people that we actually use it on. I mean, who would actually progress? Sorry, who would actually benefit from this particular condition? So we need to identify better who we can benefit. Now, current identification is mainly case-specific with patients either presenting with pathology or in a part of an eye exam. But with a 2% prevalence, you'd really want to consider screening, especially in high-risk populations, because a 2% risk of a catastrophic condition is not minimal. You know, I mean, I definitely wouldn't fly in an airplane if there was a 2% risk of a crash, and I wouldn't want a 2% risk of going blind either. Now, what is the risk of progression? This really is the crux of the issue. This is very, very important. There's actually not a lot of information on this important subject. And I'd really like to see a follow-up of the West Bengal study cohort. Now, one that has been done, this is from South India, from Vellore, and it shows that in that particular population, there's a 20% risk of progression from PACS to PAC. Now, that's actually a considerable risk. It's almost 4.5%, and may actually even be higher than the Greenland one. Now, the other thing that we really need to work on is defining what exactly is an occludable angle. Again, I know Paul Foster from 20 years ago. He was in Singapore. So he's done a lot of extremely good work. I mean, really, I only appreciate this now. So defining occludable angles again, and taking peripheral anterior synechia into account, which most of the normal grading schemes which are in use right now, they don't really take PAS into account, but you really need to take PAS into account. At the moment, it's a consensus definition of an angle at risk, which is 180 degrees of posterior trabecular wedge not visible. This has not been validated, or there's actually, again, no mention of PAS, which is a primary pathology in angle closure glaucoma, chronic angle closure. Now, gonioscopy is invaluable, but again, it's very subjective. I'm not even sure that I see the angle the same way if I see the patient the next day. You know, I can't be completely sure. Question of inter and intra-observer reliability, and I suspect the view also varies with the type of lens used. But, you know, I have 2 or 3 different lenses and I look through them and the angle seems to look different with some of them. So, again, I really think we're getting to that phase now where we're going to be screening a lot more. I don't have a lot of time, so I'm going to rush through this. So technology is moving at a rapid pace, and within 5-10 years, I think we'll be screening for a lot of these things. Now, what about OCT? Again, the pictures look pretty, but poor specificity when using gonioscopy as a reference, and surprisingly, poor inter-assessor agreements, especially for SD-OCT, which is around 55. Now, that's really not very good. This is a swept source OCT, and you can see that it actually gives quite a lot of detailed information. But again, you have to wonder, is that information really something that you're seeing, or it's not? So you need to compare a lot of these with gonioscopy. OCT is very good for a horizontal shot. As you can see here, this is one of my patients with an obviously closed angle, which I could see on a gonioscope. But I tried to take a superior hemisphere scan. Now, forget even about the lid. Forget about the lid. You just look at the 12 o'clock. Again, you know, the image reconstruction is very, very poor. So this needs a bit of a way to go. Again, now one thing that I keep coming back to as something that can be used, you know, which is not expensive, which is really the Van Herrick test, you know. I mean, I know that some of the epidemiological studies have done work with the Van Herrick test, but it doesn't show very good sensitivity or specificity, but it's extremely easy to use, and I think I wonder if there's some way that it can be made more effective. Now, I think there was a scheme proposed here to actually do that, but again, when I looked at it, you know, it's not that easy to use. You know, you have to tell the difference between a 5 degree and a 10 degree and a 20 degree. You know, one day it might look a 5 degree, another day it might look a 10 degree. You know, it's just cumbersome to use. Now, let's go to the ICO guidelines. Again, I would, you know, these are, I'm not sure it's visible very well, but you can get the, you probably get the guidelines at the booth. They have recognized the role of lens extraction. This was from 2016 for most things. Now, the tools are there. We have the tool to actually cure angle closure disease. Now, what we require for this one really is open mind and hard data. You can't accept paradigms from different areas. You know, it's not. You have to consider the local environment and logistical issues. So I think a lot of extremely good work can be done in India. This is my personal algorithm. It can change at any time. One thing which is different is that I would never do a drainage procedure in an angle closure without lens removal. It just doesn't make any sense to me. Thank you. I think we're done.
Just one comment regarding Eagle study, that in Eagle study, IOP reduction is only 1 something millimeter of mercury between the two groups. And second is in Eagle study, they are included only mild and moderate glaucoma. They are not angle closure glaucoma, not the severe one. Only mild and moderate.
I think that was the point, you know. But you would find that in almost every case of angle closure glaucoma, whatever it is, whatever the stage, you will get a significant reduction of pressure. You know, you probably want to ask more about the Eagle study from the last speaker, but there is sustained and significant reduction. There are so many patients that I have who have had their lens removed, and I see them 5 years later, no progression, nothing. Everything is open. Anything else? No?
Dr. Neeru Gupta, we'd love to hear you.
Thank you. It's wonderful to be here, and I've really enjoyed the session so far. We're going to change direction a little bit, and I just want you to clear your mind of, first of all, I want to say glaucoma, right now, everything that we do for glaucoma is lowering pressure, and so that's really our current target, even though we would love to have other methods. So couldn't agree more with the previous speakers. We know about glaucoma, it's progressive, there's vision loss, and this is the only way that we know how to treat it right now. We use a lot of different medications, a few were just raised, and we had a few surgical techniques that were sort of our bread and butter of glaucoma care, and will likely remain so based on data, including the recent Canadian report that came out on MIGS. So you might want to just have a look at that. But just very quickly, I usually have about 20 minutes to give this sort of a talk. So I'm going to, it'll be a bit of a wild ride here. So production, we know, is here. Aqueous leaves through the trabecular meshwork, and we also know that the uveoscleral pathway is involved. But what keeps transparent the aqueous? Why do you have such concentration of protein in the cellular body and the aqueous is like 1%? Well, the lymphatic circulation is a good bet. It drains fluid, it removes waste, and it defends immune function. But in the textbook, it says there are no lymphatics in hair, there are none in nails, and there are none in the eye. Well, that just doesn't make sense. So the question is, could there in fact be lymphatics inside the eye? And I'm hoping by the end of this session, you'll all look at things very differently. So let's talk about lymphatic circulation. This is a major circulation that we never talk about. 3 liters every day flows through man. It resides in our tissue spaces. It depends on high pressure to low pressure zones between arteries and veins, where you have collections of these small capillaries, these lymphatics, and 5 minutes. Well, we'll see how far we go. I hope you'll give me a few more minutes at the very end to complete this. Thank you. Thank you. So these lymphatic capillaries are blind ends that suck the fluid from within our interstitial spaces. So an illustration of this is, here's a blind end capillary sitting in of the lymphatic sitting inside. The fluid is drawn in through it, and the capillary end draws it in, and it enters by one-way valves. The valves only allow fluid to go through one way, so there's no black flow. Eventually, this propels the lymph to move through the larger lymph vessels, through the nodes, into the neck, where they eventually drain back into the venous circulation at the base of the neck. So that's our circulation, sort of lymphatic circulation 101. So back to the question, are there lymphatics in the eye? So we were very interested in this question, and here we looked at human postmortem tissue. This is the ciliary body, and here you can see clearly there's a distinct lymphatic vessel in green and blood vessel. The lymphatic is with potoplanin. This is a specific marker that they use in breast surgery pathology to determine if there's lymphatic spread. And this was also identified by EM. our question was, well, if they're there, is there flow through them? So through that, we had to use an in vivo model. We used the sheep. The eye is very similar in size to the human. We did radioactive studies. In short, the radioactive tracer was found within 15 minutes of sacrifice in a lymphatic vessel laced with LVE1. So we were confident about this, and this was published, and this was the first publication of the identification. We called it the UV lymphatic pathway. So now that we know that it exists and that it flows, can we quantify it? So we used an approach that a colleague in the past used in order to try to quantify and understand the lymphatic, what was in the leukemic patients. And so it was by gravity drip. And you can see here what we did. We did the same thing. By gravity drip, the sheep was placed. We collected the substance, the lymph from the cervical and thoracic ducts, and we looked at the composition, and there it was, and a percent was lymph. So this was also published. And of course, the sheep is a huge animal. It's big, it's expensive. There was no way we could continue studies with that, so we moved on and described similar findings in the mouse, and that's how we continue to study this. But let's just turn our attention back to the eye. So it looks like there's a lymphatic circulation in the ciliary body, and it's quite rich, and probably some of the movement through the lymphatic circulation would be through the ciliary body contraction. And so lymphatic drainage is really a third outflow pathway. And again, we refer to this as the UV lymphatic pathway because it exists in the uvea, but it also takes into consideration that this is composed of lymphatic. You can see there's a very rich network with podoplanin. So I think, we all know that now that there are lymphatics in the eye. So, and this is a reference that I would encourage you to go to. It has all of the previous work. We were, of course, very interested, now that we know that can it be manipulated? I mentioned the mouse model. And so in that model, we took mice and used hyperspectral imaging. They were put to sleep, imaged in hyperspectral imaging, and then allowed to wake up, run around, and then sequentially done it. But in some mice, we pre-treated with latanoprost, and some mice we didn't. And latanoprost, as you know, is a widely available drug, most widely. And so what we found was that the speed by which the lymph moved from the eye to the node was dramatically improved or increased in the group that was treated, so in a nutshell. And so we're very excited to be able to share a technology and an assay that we've developed now that was just recently published, in which we can now measure active lymphatic drainage in the live mouse by non-invasive near-infrared imaging. And so I would encourage you to, if you're interested in this area, to please go and read that. But the implications of this go beyond glaucoma, as you can imagine. If we have lymphatics, it helps us understand aqueous dynamics, glaucoma, immune surveillance, cancer spread, inflammatory eye disease, and even space flight. So now I want to just turn, I was also given the title glymphatics, so it's not a typo. There's lymphatics and there's glymphatics. So if we look at the back of, if we remember that we have a circulation called the cerebrospinal fluid, which surrounds the brain to provide buoyancy, nutrient delivery, and clearance. And this fluid is also surrounding the optic nerve. So we used mice, and we performed some studies and injected substance into the cisterna magna, which makes its way into the circulation so we can visualize it with some dyes. And we know that both the eye and the CNS, the fluids, are in very close contact with one another. And our question was, what is that relationship? We know that the CSF flows around in the subarachnoid space to the optic nerve here. And there's a lot of interest in the relationship between CSF and glaucoma in relation to the optic nerve. But how much do we really know? And so when we did these studies, I want to just illustrate what we did. So we injected into the cisterna magna, the dye moved through into the circulation, up through the optic nerve, and this is what we found. So we expect that we would see the dye lining the nerve. We did not expect to see it inside. So inside, so when you inject into the CSF, we saw it enter the nerve inside, and so we said, well, could this be the glymphatic pathway? The glymphatic pathway should be thought of as a major clearance system for toxins in the brain. It was recently described about 5 years ago, and we thought maybe the glymphatic system exists in the optic nerve and we didn't know about it. But in order to determine it's a glymphatic system, you must, here's the CSF, and you can see high power. The CSF is coming around the nerve, and this is a blood vessel entering into the very substance of the nerve parenchyma. And it depends on glial cells and astrocytes, which we showed in our publications, and I'll move forward with that. So this is our this publication showed that there was evidence for movement of fluid around the space into the nerve via a glymphatic pathway. So this is identification. So now you know its glymphatic pathway exists. There's this toxin clearing system that exists. And in fact, this is the way it works. So instead of just around the nerve, it enters the nerve. And you hear it comes through the arachnoid space and lines the blood vessels, and that's how it's getting in. But we were thinking, well, what happens in glaucoma? So we used the DBA model of glaucoma, did the same series of experiments, and this is what we saw. In glaucoma, we didn't see anything inside the nerve. And so this is what we're seeing. And so this was just published in December, so I'm very happy to be sharing it here with you, but there is reduced cerebrospinal fluid inflow into the optic nerve in glaucoma. And I think the take-home message is we've focused on tissue a lot. It's really important that we remember that our tissues are bathed in fluid, that there's inflow, but it means there's outflow, that waste removal from tissues is probably very important. There is a third outflow pathway that might be very relevant. And you can imagine that if you have a waste removal system that is faulty, things may not survive as nicely. And so we hope that this will inspire new hope in the field and new investigations so that we can really someday find a better way for the disease. And so when the next time that you're looking at an optic nerve, remember that probably there's probably more attention to the tissue, the fluids around is just as important. And thank you very much.
Just one question. This time in American Academy, they say this is better to, because...
Who's asking?
Yeah.
Oh, sorry, yes.
The glaucoma doctors are criticized because they are following so far the unconventional outflow system. I mean, treating glaucoma. So better to go forward because all pathobiology lies in the conventional pathway. So, and the two drugs are ready already. So now you are also telling the unconventional outflow system.
Yeah, so I think, we've always had we've had two horses, the conventional and the unconventional. And so we have our flow, and so this is really a third outflow pathway. It's untapped. I think the reality is that some of the drugs that we currently use are likely acting, at least in part, on the system. I mean, the latanoprost study in mice clearly showed that there's a stimulatory effect. That's not different from stimulation of the, mesenteric lymphatics. You can, the prostaglandins stimulate it. But, I mean, it really opens the door for new therapies. And we're very excited. I shared with you the publication about the assay, the live assay. And so we really have an assay now where we can, in live mice, examine the lymphatic system. Our first step naturally is to go to the drugs that we use every day to see which, if any, are having an impact on the lymphatic system, and be, to be able to measure it for the first time, I think is really exciting.
Dr.
think
Nehru,
it's
one
very-
last question for you.
Yes.
I mean, I know it has been your favorite research topic and you have been talking on it for quite some time. Where do you think this particular research is taking us once in, let's say, 5 years or 10 years down the line? How is it going to impact the way we manage our day-to-day glaucoma patients?
Well, I mean, the more tools and the more specialized knowledge that we have, it will increase the armamentarium for glaucoma care. So it'll open up, just as we have drugs that act on the uveoscleral pathway, drugs that act on the conventional pathway. I think by being really specific and going after this pathway, not only will we find drugs to treat glaucoma, but I think we'll find a lot of new opportunities for treating many, many other ocular diseases. But first and foremost, it's an opportunity, it's sort of a platform and a basis from which to study disease with a new framework different than what we have been using.
Thank you so much.
Thank
I
you.
think, Dr. Nehru, you've given us a very nice perspective and let's say a third dimension, or the third eye of Shiva, let's say. Okay, so that's great, and I know that we're going to see something new in the horizon very shortly. And I now request Dr. M. Nazrul Islam to proceed with his presentation, please.
Good afternoon. Okay. Good afternoon. Thank you very much. I'm really happy to be here in the 200-year celebration of the All India Ophthalmology Society, and I would thank Chairman of the session, Dr. Arup Chakraborty, and the organizers for this opportunity. I'll talk, of course, a bit different subject, but of course in glaucoma, that is treatment of angle closure glaucoma, and that is by viscoelastics, viscogonioplasty. I agree with Dr. Shauraf and Dr. Vish that glaucoma treatment still in our part is trabeculectomy, and some kind of treatment which is not expensive. We can do any procedure which is not expensive. This is first choice for us. So I'll talk something maybe very less expensive for us. I do not have any financial disclosure. So in my talk, I'll have 4 parts. So first I will talk what is viscogonioplasty. Then I will assess the current studies published in the literature about this, and procedure of viscogonioplasty, and of course my experience about this procedure. If we look to this chart, viscogonioplasty is one of the parts in the internal treatment or surgical treatment of the angle closure glaucoma. So I'll mostly concentrate on this. So what is viscogonioplasty? So you are making something so that gonio, the angle, becomes wider after your cataract surgery by the help of viscoelastic substances, so that the appositional angle closure and few peripheral antisynechia also become released. Definitely IOP will be decreased. Already my previous speaker showed that if you do even phacoemulsification, the pressure comes down. So if you have another procedure, definitely it will help. In the literature, if you search really on viscogonioplasty, you will find a lot of reports, a lot of studies that are done by different authors. I find most commonly Dr. Deepali Verma, she is working in England, she has done a lot of studies on this, starting in the last decade. She has published many studies. So first study I found in 2006 and showed that in the refractory angle closure glaucoma cases, she used this procedure and she found good result. And she published in the Eye, and next in another study in 2006, published in the British Journal of Ophthalmology with Deepali Verma and other authors, they found it is also really effective and reduces the pressure even in the chronic angle closure glaucoma cases. So they found that it is combined with the phaco. If you do the viscogonioplasty, it helps to decrease the intraocular pressure in the next day. If we look to this result and table, if we find here that, that the previous pressure, before surgery, pressure was 34, 40, 60 like this. But after 6 months follow-up, you find the pressure is 14 to 20, 18 like that. So definitely it gives less pressure in all the cases. Even in a recent study published in Journal of Glaucoma by Dr. Bogimi Sasan and his colleagues, they also found that the pressure comes down. They had the two groups, on the phacoemulsification group only, and phaco and the viscogonoplasty group, another one. So they found in their study, that phaco alone and phaco BGP resulted in a widening of the drainage angle, reduction of the intraocular pressure and peripheral antisynechia, extent of the PSCG eyes, and on the other hand, phaco BGP resulted in significantly more reduction of pus and more opening of the angle. However, it seems that additional VGP has no significant effect on the long term of IOP. So this is the procedure. I have a different procedure than other authors. After doing the phacoemulsification, you should clean the viscoelastic substances, then myose with the intracameral myotic agents, then use the high density viscoelastics, maybe cohesive, maybe dispersive, maybe Elon 5, maybe viscose, and give it in the all 360 degree. Then the other authors, they didn't do anything, they didn't use any instrument, but in my study I used a simple iris spatula, and without giving just pressure, just simple pressure, even the patient didn't feel any pain, but in 2 cases I found pain and I used the intracameral lignocaine in that cases. Otherwise the patient doesn't feel anything. And after that, definitely you have to wash thoroughly the whole viscoelastics from the surface, from the cornea, and after that you can close it. So in my about 21 months study of 135 eyes, I could analyze 55 eyes in the only phaco group, that is phacoemulsification group, and 58 eyes in the combined group. So in my study, I have found that mean IOP reduced from 32.3 to 18.7 millimeter of mercury in the phacoemulsification group, while IOP reduced from 35 to 14 in the combined group. More interestingly, a positional angle closure that we found in the phacomorphic glaucoma cases, we found that 81% were open in the phaco group, while 96.6%, nearly 97% were open in the combined group. And pus were released in 35% in the phaco group and 90% in the combined group. And of course, the good news is that we didn't have any complications in any eyes in any group. So in conclusion, I think this is very, very easy technique, and I would like to ask the audience, how many of you do the viscogonoplasty? Have you done? Anybody? Thank you very much. Not much, but actually it is very, very easy. Once I was given this topic in another forum, so I didn't know anything. So then I tried to do this procedure. I found very good results, so I made a study, and I would request you, actually very good, and really it is helpful for our angle closure glaucoma cases, especially in the phacomorphic cases, and where there is synechia is not very much, very few synechia. In that case, is really helpful. Thank you very much.
So thanks a lot, Professor Nazrul Islam. It was a very good surgical technique. And any questions for him? We didn't have 2 speakers, so we have another I think 3-4 minutes time left before we can wrap it up. Anybody is there? Anybody? We didn't have 2 speakers. Dr. Bipul Kumar Sarkar is not here, and Dr. Abba Haidara, not there. Okay. So if there are no questions for Dr. Nazrul Islam, then I think I'd like to thank all the speakers for being here. We must apologize to you for giving only 8 minutes, but then it's not in our hands. But we really enjoyed your talks, and thank you so much to the members in the audience for actively participating. And the good news is also we are recording sessions, all the sessions from all the 17 halls. So a couple of weeks down the line, everything will be uploaded and available in the Editor Proceedings website. So you can spread the word around, tell your friends who couldn't come and attend this session that, a talk is right there in the AIS website, Editor Proceedings wing of the website. Thank you so much.